but I want to go a little bit more personal. So this one is close to home for me. I don't know if you guys have known this, but viewers, recently I have had a DVT. So it's kind of a scary thing, especially if you don't know what it is. So we're going to kind of give you a little intro to what it is first, so that we can let you know what's happening.
So Brittany, exactly what is a DVT?
Right, so DVT actually stands for deep vein thrombosis. Pretty much what happens is you get a little clot, and then something goes wrong and it just gets bigger and bigger, and so you have a full occlusion pretty much blocking your vein, so there's no return whatsoever. So some of the symptoms to watch for is your foot will start to swell because your blood can't get back up, and then if it gets too bad,
Can it get worse?
oh, so it can get bigger if left untreated, which is why treating it early is so important, and it prevents the PEs, which we'll soon learn about, which is our pulmonary embolisms that go into our lungs.
Okay.
So I think we've actually prepared a little bit of the video for the viewers so they can learn about it.
Okay, so guys, audience, I'm gonna walk you through some of the drugs that you can take if you're experiencing a DVT. So, like Brittany said, we have a drug called Venous, also known as low molecular weight heparin, also known as enoxaparin. And like she said, that one is injectable, so if you're afraid of needles, sorry. But to counter that, we have new medications called DOACs, which stand for direct oral anticoagulants. And these drugs include dabigatran, rivaroxaban, apixaban, and the factor Xa inhibitors. So then we also have another drug called warfarin as well.
Yes, so warfarin does have some side effects, and older trials have already kind of shown that the new DOACs are better,
Right.
which is why I'm taking Pradaxa, which is the dabigatran. What we just talked about how doctors know how to put us on certain medications. What happens is trials are done, normally random controlled trials, and they tell us what's better, what works, which is how we know now warfarin is pretty much getting phased out. There's too many side effects.
I mean, I guess the only thing that's keeping warfarin on the market is the renal advantage that it has.
It's definitely one. That's a good point, Claudia. There is also what they call the chest guidelines right now that are happening, and those have been updated, but there was always a question that I wanted to ask. So, you know how I said I had to poke myself all that time?
Yeah.
Well, what if someone doesn't want to poke themselves, and the guidelines say if you have like cancer, you have to do low molecular heparins for life, forever. So it got me thinking, is there something out there that may be better for people who have to do this indefinitely, or at least until their cancer is gone? When you look at the chest guidelines, how they work out is you can see that if you don't have cancer like me, thank goodness, you're only on it for 3 months to 6 months, nothing crazy. But if you have a cancer risk, that's almost a 2 full times increase that you're going to get a clot. So doctors like to keep them on it forever. Can you imagine? As the PharmD ladies that we are, we have to ask ourselves, is there something out there that may prove that this is kind of the old way of the past, and maybe the new DOACs will actually work for people?
So guys, we know that you probably don't want to inject yourself for the rest of your life, right? As Brittany said. So this leads to the next part of our episode. It's article critique time! Yay! So the article that we're going to be critiquing today is actually a comparison of an oral factor Xa inhibitor with a low molecular weight heparin in patients with cancer with venous thromboembolism, results of a randomized trial. Now, this study was actually conducted by a plethora of researchers, just to name a few: Annie Young, and Andrea Marshall, and Jenny Thirlwall were a few of the contributors. So the research question that we started off with is the current dalteparin injection, which is low molecular weight heparin, in patients with cancer-associated VTE, safer and more effective compared to oral rivaroxaban? So the study design that was used was a multi-center randomized open-label pilot trial conducted at 58 sites within the United Kingdom. The study period of this trial was from September 6, 2013 to December 22nd of 2016, so roughly 3 years. And the follow-up period was every 3 months for 1 year, and then every 6 months for 2 years. The patient population also that was studied was constituted of approximately 406 patients total, which is a decent size, and 203 went to the dalteparin group, and then 203 went to the rivaroxaban group. And mind you, dalteparin is low molecular weight heparin, and rivaroxaban is a DOAC. So the analysis was intent to treat. So the purpose was to treat. And the power analysis was actually not reported. So no reported power was found in the article. Here you can actually see that of the different baseline characteristics that were, analyzed, the white ethnicity constituted of approximately 96% and 94%, which meaning that was a very high number of a particular group. 96%, that meant that only 4% was like other ethnic groups as well.
And you've got to think, we are, the PharmD ladies, and where are we but in DC? So
exactly. So in DC, we know that the population is definitely not reflective of the population stated here in this article.
I mean, they had a good mix of females and males, so that's
yeah.
nice and helpful. And they did do a one-to-one matching, which is great. That we'll go on to discuss.
Yeah.
This article, and I'm just going to kind of show you some of the inclusion and exclusion criteria. So they had to be over 18, which is good, and they did have to have a certain kilogram weight, which, as we know, good renal function in kilograms you need for a low molecular weight heparin. I mean, less than 30. For your creatinine clearance, you can't even really use it that well. So that's why it's good that they had all the criteria that they did. However, they did have a lot of things they couldn't add in. So if anyone was on any warfarin before, any DOACs before, they couldn't do it because they couldn't see if that was the real reason for it. Right. And there were also some other medications that the patients were on, or if the patient was treated more. So if you come into a hospital and you have a PE, doctors are going to want to treat you right away.
Yeah.
But if you were treated for more than 72 hours before you were put into this trial, they had to exclude you.
Exactly.
So it was,
makes sense.
it was very hard for them. They actually wanted a lot more people than they got, which is why it was hard for them to do some of the statistical analysis. So out of those people, we had a lot of things from what we talked about before that took them out, and it was just really slow recruiting. So I think their aim was way higher than what they actually got, but it just ended up with 406 actually saying they were okay. I mean, almost 264 people said they didn't even want to participate in this study. So as far as what we're actually looking at, our independent variables, the ones that actually affect everything, are our treatments that you've been talking about. So our DOACs versus our low molecular weight heparin. They actually did an okay job. They let you know how they worked and the basic information on them, but there was no details. I mean, they didn't even explain how painful the injection sites were and things like that. So I feel like there was some details lacking, and even pharmacokinetics that were lacking that could have been added to this.
Yeah.
And then as far as dependent outcomes, we had our primary. So what they were initially looking at is if you had cancer and you had this happen and they put you on one medication or another, you're likely to get it again, which we don't want because that would be the PE.
Right.
So they actually were looking at reoccurrence, and they looked at it if anyone got any sort of clot, a PE or DVT in 6 months, or if the medication actually stabilized theirs and prevented this. And then the other outcomes were major bleeding risk.
Anticoagulants definitely can cause bleeding if taken too much and if they get toxic in the body. Those are also side effects that viewers at home you should look out for if you are on these drugs. Let's say that if you're brushing your teeth and you notice that your gums are bleeding and it's not stopping, please go to your primary care physician or go to the emergency room.
Right, and that's our major bleed. So that was one of the second ones. And then the other one was their clinically relevant but non-major bleeding. So this would be your bruising that you see, or things that weren't going to be as severe, but they still actually looked at it to keep track of everything. And then there were no genetic factors.
Yeah.
Family support. Sometimes if you have problems with being weak and cancer and you have to hold those injections to you. And then our last one that Claudia noticed
was the chronic conditions.
Correct.
Right, because they didn't assess what chronic conditions that patients had prior to joining the study.
So as far as statistical analysis, because like I said, they wanted a bigger sample size, they just couldn't get it. Their 95% confidence interval was of the 9% instead of their original 8% that they wanted. They also didn't do any, as you guys have probably known in our biostatistic lectures before, no multiple linear regression, no recoding. So we actually didn't have a lot to report other than they just did a survival ratio. All their stuff was just hazard ratio.
Okay, so now we can talk about the results. So for the results, we have primary outcomes and we have secondary outcomes. For primary outcomes, the major one was the reoccurrence of the VTE at 6 months. So for the two drugs, dalteparin, it was 11%, and for rivaroxaban, it was 4%, with a hazard ratio of 0.43 at a 95% confidence interval. So for the other outcomes, the secondary outcomes, we had major bleeding at 6 months, and then we also had CRNB at 6 months, and then we also have overall survival at 6 months as well. Brittany, can you explain what CRNB stands for?
Sure. So that's actually what we were talking about before, just their acronym. That actually means the clinical relevant but non-medical bleed risk. So they had study pretty much, and they were all within the nice confidence interval that we learned. So they're significant for what the hazard ratio can say. So when you're looking at all of our results, and we'll show you on the graphs too, 11% means that the drug actually had more recurrences, which we didn't want.
Exactly. It was high, and so that was nalteparin that had the 11%, whereas the direct oral one had 4%, which was lower, and that's what we wanted.
Yeah, I definitely want a 4% chance of getting a recurrence versus 11. And then for the bleed risk though, the major ones were about the same, which is good. No crazy side effects.
Yeah.
But those minor that are still relevant, those bleed risks that they had, 4% had them for the low molecular weight, but over 13%.
Right, for rivaroxaban. So showing that for rivaroxaban, which is the DOAC, which is good for the primary outcome, it's actually bad for the minor bleeding risks as well.
Right, and the survival rates are pretty close. I mean, 70% versus 75%. Deaths were pretty close, so it's hard to even say which one is
better because they kind of have their ups and downs.
So we also wanted to take a part of the graph because they didn't do any statistical analysis as far as linear regression or multiple linear regression. They had pretty much tables set up over 6 months following people. So as you can see on the first graph, the one was the time of your reoccurrence. So as the time goes on, with the low molecular, which is the yellow line, people had more likelihood of getting a reoccurrence versus the nice rivaroxaban that kept reoccurrence down at that 4%.
Here we have the bleed risk, and as we explained prior, the results have flipped. Where for the purple line, that's rivaroxaban, and if you can see, it's actually higher than nalteparin, indicating that rivaroxaban has a higher bleed risk.
So as we were going through the article, we kind of already mentioned some things, especially with the population in DC, but the lack of power is kind of a big one for me. If you have a randomized controlled trial, you should have a power because that tells you how they relate and how effective your study is. Also, since they didn't have any statistical analysis, they just had the analysts of the hazard ratio, we only had really one thing to look at and no predictive factors on whether certain people were more prone than others.
Another thing I noticed was that the data only went on, or the trial went on only for 6 months. We only have 6 months worth of data, which I think presents as a weakness. Because if we're dealing with a DVT, such a serious condition, you want to know the effects after years.
Especially since they went for 2 years, where's that data? And we're doing this for life. We want to at least see a little bit longer than 6 months. And then we did it. We do have to mention though that the study was funded by Bayer Aspirin, and Bayer, as you know, does make rivaroxaban, and a couple of the people on this were also funded. So not saying that they would do anything, but you do have to take that into account.
Yeah, conflicts of interest.
Right. Other than that, the pros for the study were definitely matching. They did a good job getting everyone in, and as well as they could.
Although there was low recruitment.
There was low recruitment.
In conclusion, our main study objective was to find out if it would be possible to take oral medications opposed to injecting yourself with a low molecular weight heparin all the time, So, in conclusion, rivaroxaban is associated with relatively low VTE reoccurrence. However, it is also associated with increased bleeding.
Right, about 3 times, but for the minor, not the major risk, but 3 times for the minor risk.
Yeah, for the minor risk. So, injections also have a less adverse effects of bleeding. However, they might not protect you as well against the DVT recurrence.
Right. In the long run, after watching that video, what is more important? Some bruising and minor clinical relevant bleeding, or a pulmonary embolism possible, or a stroke. So I feel like this trial is just the next one that's going to add, showing that DOACs, despite the slight increase, may be better for patients, especially long term, because I don't know about you, but pulmonary embolism is going to be a little bit more than bruising.
Yeah,
so.
that's frightening. So I think our major stance is that the DOAC, rivaroxaban, is much better than low molecular weight heparin.
I think so too. So that concludes our show today. Before we end, thank you for tuning in with us.
Yes, thank you.
And we just want to say thank you. We got some good information from one of our professors, Dr. Wingate.
Yes, thank you, Dr. Wingate. And lastly, we would like to thank the Department of Administrative and Clinical Sciences at Howard University.
So we hope this was educational. It was something close to my heart. I hope you guys learned something. And this article, actually, you might see a guideline update from it. I feel like despite some of the drawbacks, it was overall pretty good.
So here we have our references. As always, thank you so much for watching. We are
the PharmD ladies, so tune in next time.